So it's 7:34. We will get started. And typically I do a basic introduction of the huddle, but because I see that all the attendees are our regular attendees, I'm going to skip the introduction. I'll directly go to the case for today. Now, the case for today I have selected primarily because of my discussion with one of the colleagues that I had a couple of months ago. Okay, let me fix it. Am I audible to you guys? Somebody gave a feedback that my voice is not very good.
You're audible, Anup.
Okay, all right, perfect. So a couple of months back, one of my colleague and me were discussing about the role of anticoagulation in a certain subset of patients who are not categorically represented in the routine trials. One of that subset is what we are going to talk today. And it just happened that a very small but relevant trial was published just 3-4 days ago with regards to this. So let me bring in the clinical case and then we will initiate our discussion and see what the attendees think about it. So Praneeth, I will get your impression first. This is a 56-year-old male who came to me about 2 months ago, and he was primarily the reason why we had this discussion. He came to me because he was having dyspnea for about 2 months. The story goes is he is hypertensive, non-diabetic. He takes medications for about 8 to 10 years or so. He's a little bit obese. He runs his own business. And he was complaining of chest pain about 3 months back. At that time, he didn't really notice. He said that for a few days, I was not feeling well, so I took a rest at home, but didn't seek any medical attention. He was otherwise feeling fine. The chest pain kind of resolved over the time, and he was feeling okay. But what he noticed since then is that slowly he started developing dyspnea on exertion. It started about a month later, and now it's been gradually progressive. He does have occasional PND episodes, but certainly no orthopnea, no resting symptoms. He's otherwise able to mind his business, albeit a bit slowly than what he was doing before. So that was his main complaint when he came. On the clinic visit, on examination, there is clear signs of fluid overload. He has got some basal crepes. His jugular venous column is elevated. He has got a touch of edema, not a lot, but he's breathing all right. His saturation is all right, and on minimal ambulation in the OPD itself, he's doing fine. He's not in any distress of any kind. I check for routine laboratory findings like hemogram, renal function, and whatnot, and they're all okay. His cholesterol is elevated. His LDL is about 150. He doesn't remember when was the last time his cholesterols were checked. I also did an ECG which showed loss of R wave up to V4, and he has got a tiny R wave in V5 and a preserved R wave in V6. There were no any signs of acute ischemia. His echocardiogram showed akinetic anterior wall with an ejection fraction estimated around 40%. And there was an obvious left ventricular thrombus at the LV apex, which was measured somewhere around about 15 to 20 millimeters or close to 2 centimeters in some dimensions and 1.5 centimeters in some dimensions. So he currently is not having any chest pain or anything. So I didn't see any need of doing an urgent angiogram on him. I certainly wanted to define his coronary anatomy, but that was not the pressing need at that time. The need was to take care of his heart failure and also address his LV thrombus. Now I put him on some heart failure therapy. We're not going to discuss that part. I want to restrict our discussion to this LV thrombus part. Now, because by definition he has got coronary artery disease, I put him on antiplatelet as well. And because it was the onset of disease, I did put him on dual antiplatelet. My intention was to put him on dual antiplatelet for some time and then later on back off a drug depending on how things evolve. The decision was on the choice of anticoagulant therapy for this LV thrombus. He undoubtedly needs anticoagulant therapy. And for patients with left ventricular thrombus, post myocardial infarction, the role of vitamin K antagonist versus NOAC, in fact, none of them have been defined. Truly speaking, I have never read a trial evaluating the role of vitamin K antagonist in LV thrombus. It just was assumed because vitamin K antagonist is the therapy for thrombosis that essentially became the de facto therapy for left ventricular thrombus, and that is what comes up in the recommendation, and that is what we would consider as a standard of care. On the other hand, what we do know is NOACs have been coming up quite interestingly in a lot of patient subset. We know about atrial fibrillation, pulmonary embolism, DVT. There are a lot of patient subset where they have not only established as an alternative to warfarin, but to a certain extent safer and more effective than warfarin. And they are certainly easier to take. So I think it will be unfair not to question the role of NOAC in this particular patient subset, understanding that there is lack of data about it. So this is one decision I had to make. And remember, this patient will be on dual antiplatelet as well, at least based upon my clinical impression for the first few weeks, if not months. So the question for this case is, should we choose the old school vitamin K antagonist versus we choose a NOAC, understanding that NOAC lacks any good data, and truly speaking, for that matter, even VK lacks any good data. If you do want to go with NOAC, the question will be which one and at what dose, or if you have altogether a different approach, both in terms of NOAC as well as antiplatelet. So we are trying to talk about anticoagulant, antiplatelet strategy in this particular patient who by diagnosis has got an evolved anterior wall MI, who's angina free currently, but has got some heart failure symptoms, which can be managed as an outpatient, and has got a LV thrombus, which needs to be handled. So Praneeth, how would you manage his anticoagulant therapy? We'll hear your impression and your rationale of choosing, and then we will go with our attendees for their impression. Praneeth.
Yeah, good evening, everyone. So, Anup, as you said, this case essentially the coronary artery disease point of view, at least the ischemia is not active. Whatever has to be managed is the heart failure, which we already are doing, and the current topic of discussion is about the LV thrombus, which we have to deal, and because of its risk of embolization and its subsequent events. So, with CAD and some indication for anticoagulation, the indication of giving antiplatelet therapy, single versus dual, and anticoagulation. So, this patient, because he is not revascularized, or at least we don't know his anatomy. And the younger patient, I would say definitely we can consider dual antiplatelet therapy and some form of anticoagulation. Versus if I think that his risk of bleeding is high, then I would consider giving him only single antiplatelet therapy. But I agree with your point of giving him DAPT for earlier few weeks and then probably step down on one of the antiplatelet therapies. Now coming to the question of anticoagulation, so this he needs more importance than the antiplatelet therapy, I believe. And ideally speaking, whenever we talk about anticoagulation therapy, what I look at is the absolute indication versus so-called relative indication of NOACs. NOACs is always comfortable because of the headache of monitoring PTINR therapy and PTINR test and the restriction of leafy vegetables, getting the PTINR checked, monitoring, getting in touch with the physician or the assistant to monitoring the dose of the vitamin K antagonist becomes a bit difficult. In that way, NOACs are easy to advise. Patient need not worry about a lot of these things, and it's always comfortable. So whenever I have an established indication, so NOACs are the preferred choice. Now, as you said, in this case, the so-called that we know is we don't have a clear indication of NOACs being given. If the patient is reasonably educated enough and if I'm in a position to convincing about usage of vitamin K antagonist and monitoring the PTINR and importance of checking the test, and if I can get them confidence, so I would prefer him to put on vitamin K antagonist, which at least we believe is the standard of care. Versus if I have a doubt where monitoring and other practical considerations are there, then I would be preferring to give NOACs. And among the NOACs, my drug of choice would be rivaroxaban, again for the sake of uh, the ease of administration of a single pill, where the patient compliance is better, and now with the current price reduction, it becomes a favorite choice. So if I have to give this patient rivaroxaban, then I would give him full dose of rivaroxaban of 20 milligrams, give probably 75 milligrams of clopidogrel and 75 or 150 milligrams of aspirin for him, and then maybe cut down aspirin after some time and continue with clopidogrel and rivaroxaban 20 milligrams for him, and look for the response. So that is my take on this patient.
So Praneeth, if I hear you correctly, that if you have a patient who is compliant and understanding and everything, let's say if I am the patient, you would suggest me to be on vitamin K antagonist, if I'm reading it correct?
Yes.
Okay, all right, perfect. So let us move forward with the discussion. And again, this is a gray area because LV thrombus, ischemic LV thrombus, we're never going to have the kind of robust studies that we typically have with let's say non-valvular atrial fibrillation or DVT, which are far more commoner. So certainly that high quality data is unlikely to be there with us. Having said that, we do have to put some of our own understanding and extend what we already know. I also need to discuss what you mentioned about the nuances of warfarin and the inconvenience of checking INR and all those things, which are of course inbuilt whenever we put patient on warfarin or acetrom or something like that. So I'm going to continue my discussion. In the meantime, if anybody has got any questions or comments, they can raise their hand or unmute themselves, or they can post their questions in the chat box. I have Dr. Srinivas here. Dr. Srinivas is a cardiologist at Care Banjara. Sir, if you could unmute yourself, you heard the clinical case. How would you handle this patient's anticoagulant therapy, and what is your rationale about it?
Yes, I would agree with most of the points with what Dr. Praneeth had said. And in acute coronary syndrome, the first 3 months would be a hypercoagulable state wherein you would require dual antiplatelets. And the LV clot, I'm not sure whether it is a fresh clot or organized clot, but even then, to prevent any further clot, since it is a akinetic area, we would require anticoagulation. And there's no randomized trial which had compared the warfarin versus the NOACs in case of LV thrombus. We have evidence in atrial fibrillation, pulmonary embolism, but not in the case of LV thrombus. So, and some evidence shows that the incidence of embolism is less with the use of warfarin as compared to the use of NOAC. But if the patient has other indications like the presence of macrovascular complications in other territories, being in the form of peripheral arterial disease or carotid artery disease, along with the presence of coronary artery disease, then it argues in favor of NOACs because NOACs have been proven to be of much higher efficacy in these subset of patients as compared to warfarin in various trials.
Perfect. Thank you so much, sir. And truly speaking, when I put on this topic at that time, what you said was absolutely correct. It just so happened that a few days ago, a very small trial was published, if I remember correctly, from Turkey or Egypt or somewhere, where they studied about 80 some patients for rivaroxaban versus warfarin. And they showed rivaroxaban non-inferiority over warfarin in treating LV thrombus. And the non-inferiority was mostly there for the first 3 months. By the end of 6 months, the drugs were pretty much equally effective. So at least we know that it's not a bad choice. Whether it's a better choice or not, that question is still unanswered. So we do have some data. Of course, while it was a randomized data set, it's a very small population, and it's an unblinded data set. So we take whatever we have got. So certainly, logically it makes sense, and now we have at least one data to code for. I'm going to go forward and invite other colleagues. I have Dr. Chandramukhi with me. Dr. Chandramukhi is a cardiologist at Care Banjara. Dr. Chandramukhi, I believe you heard the clinical case. If you could unmute yourself and tell us how would you manage the antithrombotic therapy of this patient.
Good evening, all. Dr. Anup, I wanted to ask how is the LV function of this patient and how is the LV dysfunction?
Ma'am, it was reported mid and distal anterior wall akinesia with estimated ejection fraction about 40-45% or so.
So this may be considered as mild LV dysfunction. And this patient has not undergone any PCI. He has a history of acute coronary syndrome about 2 months ago, and now he has presented with heart failure. So in this case, am I right, Dr. Anup?
Yes, ma'am, you're absolutely correct. You're absolutely correct. Yeah.
So in this case, I would like to go with oral anticoagulation, preferably in the form of NOAC and clopidogrel 75 mg once daily and rivaroxaban 20 mg orally. And if the patient had undergone PCI, then I would have recommended triple drug therapy in the form of ecosprin and clopidogrel 75 mg once daily and rivaroxaban 20 mg once daily for about a month. And later on, rivaroxaban 20 mg OD and clopidogrel 75 mg OD.
So you wouldn't give him upfront triple therapy, I'm guessing, unless the patient undergoes angioplasty. Is that correct?
Yes.
Okay, perfect. All right. And ma'am, why did you choose NOVAC? Why you didn't choose vitamin K antagonist?
As already mentioned that NOACs, especially rivaroxaban, has been proved to be non-inferior to the oral anticoagulants like acetrom and warfarin. And already Praneeth has mentioned that there will be some inconvenience for the patient testing the INR frequently, and there will be fluctuations in the INR. And again, in the first initial days, we have to keep adjusting the dose of the warfarin or acetrom. So like NOACs, they have the convenience of maintaining the same dose, and they have to be taken like rivaroxaban once a day. So there is convenience in the dosing and compliance of the patient also. If there are no affordability issues, I will definitely go with rivaroxaban. If the patient is having any financial issues, then I will consider acetrom or warfarin.
Perfect. Thank you so much, ma'am. Let me call in Dr. Shankar. Dr. Shankar is a senior physician who had been a regular attendee of our huddle. Dr. Shankar, if I could get your insight, particularly not just for this case, but also challenges of warfarin and INR management in your practice, because I'm sure you face it far more frequently than what we do. Dr. Shankar.
Thank you. Good evening to all. This is an interesting case where we are faced with three problems in the same case. One is LV dysfunction, and second is the revascularization procedure, in this case of ACS of 2 to 3 months. And the third one is, as we are discussing now, regarding the LV thrombus. So, even though there is no robust evidence for the NOVAX, even if it is limited, even though earlier it was very costlier, and there were no antidotes to reverse the activity of these NOVAX or DOVAX. But now the evidence is accumulating fast, because earlier we were giving only for the prevention of stroke with atrial fibrillation or management of VTE, either PE or DVT. But now the indications are expanding like anything, because they are very good molecules. So like in the ACS also we in the peripheral arterial disease we give, even before cardioversion also we give this NOVAX. Earlier we used to give warfarin, but now Even a short duration of Novax can be given to do cardioversion. And even in the ablation also, we give Novax. So likewise, many indications are there. Gradually they are expanding and the evidence is accumulating. And just now it is told that it is non-inferior to warfarin, the river. So I prefer the rivaroxaban because the evidence is accumulating and no monitoring is essential in this case. Unlike warfarin where PT-INR has to be done regularly. This is very, this is quite variable. Even if you send the same sample to 3-4 labs, 3-4 labs, they give different readings. So whom to believe, unless the patient comes with the bleeding and correlates with the INR, then only we rely on the lab data. So this is very difficult to monitor. And at the same time, I have seen my patients, they are years together, they have been continuing the warfarin or acetrom without doing any PT-INR. So even if we write that every 3 weeks or every 4 weeks this PT-INR has to be done, they never get it done. Even if they get it done, different labs, they give different readings. Whom to believe also, it's a problem. So there is no standard lab data regarding the PT-INR monitoring. So that is the only problem with the warfarin. And otherwise, and second thing is drug interactions are there with the warfarin and food interactions. They cannot avoid leafy vegetables, the green leafy vegetables. We insist on avoiding them, but it is very difficult to comply with the patient. So this is the problem with the warfarin. Food interactions, drug interactions, monitoring is a problem. That's why I prefer Novax. Now it is evidence is accumulating. No monitoring is necessary, and now it is available at an affordable price. Your rivaroxaban, it is 30 rupees a day, and hardly we may give for 3 months, or we may extend it to 6 months, unless the indications are there for the indefinite use of rivaroxaban. So 3 months means it comes to only 600 rupees or something. So patient can 600 into 630 into 3, 900 into say 3 months. So 2,700 only. So it's not a problem for the patient to bear the expenses. And no food interactions. So when a few drug interactions are there, like with dronedarone, amiodarone, phenytoin, or ketoconazole and others. So I prefer a rivaroxaban 20 milligrams per day, because here the dosage schedules of these Novax is different with the stroke prevention of atrial fibrillation patients and patients with VT, venous thromboembolism, like PE or DVT. So here the evidence is going towards as if we have to treat the patients with the AF for the stroke prevention in this case of LV thrombus. So 20 milligrams per day I prefer to give, and this is nowadays it is affordable also. And the second thing is the dual platelets, because it is it comes under ACS, whether it is stented or PCA done or not, but we have to give dual antiplatelet agents. But only the problem is where there is no robust evidence that there is bleeding risk may be there. But compared to warfarin, the bleeding risk with the Novax is less. So I prefer to give clopidogrel, no doubt about it. P2Y12 inhibitor is a must. That clopidogrel. But regarding the aspirin, as Dr. Chandramukhi told, we can give short period, or we can weigh the thrombotic and bleeding risk, looking at the Chandwa score or Hasbled score, and depending on that, whether to give aspirin, whether to add or not, we have to decide. Once the 3 months of treatment is over, once the thrombus is resolved, we can switch over to the dual antiplatelet agents, aspirin plus clopidogrel or ticagrelor with aspirin we can give, depending on the intervention.
So, Dr. Shankar, do you have any patient who does home monitoring of PT-INR?
Oh, there are. See, I talk to about people. They wanted to arrange this thing, but it is not. They wanted this facility is there. If we demand the particular company, a Citrom company, they will provide this home monitoring facility.
And do you think they are reliable? Like, let's say if Abbott or Roche or some company, if they provide the device. That's
what I'm telling. This is very interpersonal variation there, intra-observer variation is there, lab-to-lab variation is there, and company to company. So this is very difficult. See, here what many of my patients, they come with INR 6 and they come with cough, hematoma, or bleeding diathesis. So many problems we encounter. Even intracranial hemorrhage also. Recently I have seen one patient put on warfarin. He came with the intracranial hemorrhage. And GA bleeding is also there. So it's very difficult to monitor these patients, especially to rely on PT and INR to adjust the dosages.
Perfect. Thank you so much, sir. I'm going to move forward. Let me ask Dr. Praveen. I think Dr. Praveen also has a few cases that he wanted to share. Dr. Praveen, if you could address the current clinical question that we have, and then if you have anything to share, please feel free. Dr. Praveen.
Good evening, everyone. Sir, in this case, I would go with triple drug therapy, sir. I would be keeping ecosprin of 150 mg, clopidogrel of 75 mg, and I would go with acetrom, sir. I would be keeping around initially of 5 mg, sir. Considering if the patient is from the if he consults a government hospital. Now, if there are no any financial constraints or anything, I would go with rivaroxaban 20 mg, sir. The duration of therapy would be for 3 months, and then I would be doing the echo, and if there is resolvement of the thrombus, I would be posting him for angiogram to see the revascularization status of the patient, and then put him on the subsequently dual antiplatelet therapy.
Okay, and Praveen, you mentioned about the affordability and cost related, and I understand that in government setup like Osmania, the way we look at the out of pocket expenditure slightly differently than what we do in the private sector. But let me ask you a question as a general. When you put patients on vitamin K antagonist, be it your warfarin or be it your acetrom, and if you do PT-INR the way it is supposed to be done, not necessarily that a patient gets one test done in 3 months, but the way it is supposed to be done, and with the travel cost and everything associated, do we believe that warfarin therapy is a cheaper option to the patient as compared to novel anticoagulant? I'm just being a devil's advocate. What do you think?
No, sir. If you take into consideration the vitamin K antagonist, the traveling cost, and as well as the PT-INR, say for example, if we do every 15 days or once in a month, then the difference will be very minimal compared to that of usage of rivaroxaban 20 mg. But Issue is, sir, what we face when we ask any patient to use a new drug. Say, for example, the now the price of the rivaroxaban has come down. The recently, 2 months back, we had a patient with venous thromboembolism. We kept the patient on 20 mg of rivaroxaban. After 1 month, the patient came without any complaint, just for the follow-up, and straight away said that, sir, I can't afford this medicine. Why? Because the initial 1 month, almost all 15 days was given by the pharma representative, and they said that the whole month cost around 1700 rupees, the rivaroxaban. So that financial consent is there, but again, if you consider the whole of the vitamin K antagonist usage and the PTANR, again it amounts to the same thing. But from the patient perspective, when it comes to even a difference of 500 rupees, they go to an extent that they will be stopping that medications rather than keeping the extra amount of money. If the patient is the whole sole blood runner of the family, that issue will face, sir. They will be coming, they will be ignoring the medication, they will be coming after 3 weeks when they feel some unusual, what you call, complaints like palpitations and all that, where it will be out of reach to completely manage the patient. This is the one I faced. I kept the patient on rivaroxaban because the pharma people can't give every time the samples. So they said that, sir, we can't use. And for venous thromboembolism, at least 6 months to be used. So that was the issue we faced.
Certainly, that is very relevant. I think that the upfront cost versus a later cost, that is what we typically talk about, preventative therapy versus reactionary therapy, where we know that preventative therapy is upfront, so many of the times people don't like it, versus reactionary is something which is in the future, which people are forced to pay. That is typically what happens in vitamin K antagonist, where later on, either because of INR dysregulation or warfarin itself, they end up with the cost of therapy towards the end. Sometimes, and I'm not saying all the time, but sometimes end up becoming more than what they have saved. Dr. Praveen, if you have any questions or any clinical scenarios or anything that you want to discuss, please, if you don't mind typing it in the chat box, or you may come
Sir,
out.
just give me 2 minutes, sir. I want to just share the three and because all the faculty are there. I just want to know their opinion.
Sure.
We had these are. I'll just wind up in 2 minutes, sir. 3 cases are there, sir. We had an 50-year male, sir. He presented lately, almost all after 30 hours to us. The diagnosis was infero-postural MI, sir. So at AMC, when we have seen, the patient was having moderate LV systolic dysfunction, and the LA size is of almost all 4.5. On the infero septum was akinetic, and the lateral was also akinetic. He was having the lateral was dyskinetic, and the patient was having thrombus. So patient was also having MR because of the immobility of the PML. So this was one case scenario. The next case scenario was patient came with no complaints. He was a chronic diabetic. He had no chest pain. He admitted in medical ward because of the pedal edema and all that. The medicine people have just for what you call referred us to do an echo because the ECG was showing QS complexes from V1 to V5. When we have done the echo, the patient was having akinetic anterior wall apex. The LV function was 40. Now, surprisingly, the LV clot is almost all half of the LV is having the clot with 21 centimeter square area, surface area, and there were multiple resolution of the thrombus with the proximal half of the thrombus wavering with each contraction. This is the second case, sir. And the third case was this is a female. She had burns over the proximal half of the leg, and subsequently she was found to be having DVT in the right femoral vein, and she presented with shortness of breath. We kept a diagnosis of pulmonary thromboembolism. We started her on rivaroxaban, but she had a history of fibroids. History of fibroids, and the hemoglobin was 7. So we started on rivaroxaban, and the patient presented with GI bleed and bleeding her vagina. So these three case scenarios. So in the first case, we kept him on a heparin infusion, sir. In the first two cases, there was slightly resolution and all that. In the third case, we could not do anything. Of course, the patient has been stabilized by after blood transfusion. So these are the three different case scenarios, sir. Any inputs?
Yeah, so I will ask my attendees to give their input as well. I have one question, Praveen. In your first case with the MR, was this patient a surgical candidate? Was the MR that significant?
Sir, MR was significant, sir. It is what you call more than moderate.
Yeah, because if the patient is there with a mechanical or active ischemic MR and has got a thrombus, then sometimes the easier way out is to surgically revascularize them, which takes care of the revasc plus MR plus the clot. In your second case, with the clot size being almost 20-21 centimeters, I think this will scare any person. And I would ask my attendees if anybody has got any thought about how to handle this large clot. And then,
why we were concerned, sir, sorry to interrupt you, sir. Why we are concerned for this patient is relatively stable, sir. Only just he had a pedal edema. We were concerned that seeing that much large thrombus, if we give any of the IV heparin or anything, that would what you call lead to obviously embolization and all that. We were very much concerned. We have taken the CT surgery referral also. But from our perspective, what we can do, I want to know.
Yeah, no, certainly. I think the point that you raise is very relevant, that at what clot size even we get concerned about anticoagulation at all, regardless of whatever therapy we use, and rather send for surgery with a so-called surgical evacuation. Your third case, I think, with a pulmonary embolism and DVT, with a hemoglobin of 7, I would suggest if there is no any respiratory issue, then maybe just put a filter and let her anemia settle, and then take the filter out. That could be one possible way, but it's a difficult scenario to manage. So I think one question that I can put up to my attendees is, at what point in your LV clot is it too big for you to handle with anticoagulation? And there you ask surgeons to do a so-called surgical evacuation. That would be a reasonable question to ask the attendees as well. But before I do so, I'm going to go back. In fact, I have a question for Dr. Shankar. Dr. Shankar, I have a direct question for you. In your discussion, you were mentioning about one of the reasons why you chose NOAC over vitamin K antagonist is because of patient compliance, lab variability, and dietary restrictions and everything. I'm just giving a hypothetical situation. Let's say if the patient is me, who is pretty much compliant to you, and I don't care about dietary restrictions and everything, with the clinical scenario that I gave you, which is evolved anterior wall MI and a LV thrombus of 2 centimeters, would you still put me on NOVAC, or would you put me on vitamin K antagonist? I got sense from you that you were quite in favor of NOVAC.
I still give NOVAC only because the bleeding risk is less with the NOVAC.
Perfect. That is the kind of answer I wanted to hear. Thank you so much, Dr. Shankar, because I think that it makes the decision making, at least from the rationale that Dr. Shankar is coming from, very clear. that no matter how you look at it, NOAC do seem to be holding a superior ground, or at least non-inferior ground, to warfarin, and should be offered as a first-line therapy as compared to vitamin K. Let me get to other attendees of this meeting. Dr. Prashant is here. Dr. Prashant, I don't know if you got the clinical case or not. We are talking about a 56-year-old male with evolved anterior wall MI and has got a LV thrombus. We are trying to figure out what should be the antithrombotic regimen for this patient with regards to vitamin K antagonist versus NOAC, understanding that none of them have got good data. Which drug would you choose and why? And the second question that Dr. Praveen asked is, at what point your LV thrombus becomes too big that you say, now I cannot handle it, I should ask surgeon to evacuate it? Dr. Prashant, if you could address these case scenarios.
Good evening, sir. Sorry, I joined late. For choosing between vitamin K antagonists and NOACs, nowadays NOACs is a better choice because of obviously less bleeding issues. And nowadays we have many companies with the lower pricing available. So mostly we use dabigatran, which has more options available and easier availability. So 150 milligrams twice a day. And what size, that I don't know, but I definitely in the last 3-4 months I got 2 patients for whom I did viability study, and then we sent them for surgery. So what size of thrombus, I'm not sure what to do for them. If it is a large thrombus or a small thrombus, I usually start them on anticoagulation, but always with the risk of embolization, and explaining them the stroke risk. Getting a viability study done and then sending them for surgery is a better option, because as it is, if they are presenting late, their myocardial viability is most often is jeopardized. So that is it, sir.
Perfect. Thank you so much, Dr. Prashant. And I agree with you. I don't think there is a standard cutoff in terms of how large is too large for you to manage medically. Let me ask Chandramukhi madam. Madam, you do echoes on all these patients. At what point in your echo finding you say that, oh, this LV thrombus is too bad for us to manage and should be managed by surgeons? Do you have any criteria for you?
No, I don't have any criteria regarding the size of the thrombus, how large it is that we should send the patient for surgery. But if the thrombus is associated with aneurysm, then and if there is significant LV dysfunction and it is causing heart failure, then we can send the patient for repair of the aneurysm and declotting. And if, as Prashant says, if there is like other areas of the are viable, then we can send the patient for surgery.
Certainly, I think if the patient meets further criteria for surgery, then certainly it adds value and the decision making becomes easier. But if they don't fit in any other criteria, we are talking about the sole surgical criteria being LV thrombus, I think this decision is difficult. And to my knowledge, I don't think there is any particular algorithm on how we use. Somebody mentioned, I think Prashant mentioned about dabigatran as well. People who do use dabigatran, I just want to highlight 2 things which is off the topic, but because we are talking about NOAC and vitamin K antagonist, we need to know this. Number 1 is dabigatran, while being a cheaper molecule, with the current price reduction on rivaroxaban, that doesn't hold true anymore. In fact, the price differences are not much. That is one, and this is a newer development, maybe in the last 1 month or so. The second is dabigatran efficacy is dictated by how much tartrate content it has. And I believe only few Indian manufacturers put 33% tartrate content as compared to others. So that is one thing that we have to address. So the same 150 milligram of dabigatran across different brands may not have the same kind of efficacy. The third thing is dabigatran is a hygroscopic molecule. So if patient keep the drug exposed, or if the packaging is not airtight, then the dabigatran hydrolyzes on exposure to air, and it causes higher incidence of GI bleed, which was one of the very contentious scenario for lawsuits in the United States against dabigatran, while it was causing a lot of GI bleed. We started with dabigatran as it was the first DOAC molecule for us, but very soon we switched to the other ones, which is 10A inhibitors, primarily because of these reasons. Quality control was a problem, hygroscopic nature was a problem, and GI bleed was a problem. Having said that, it certainly offered a cheaper option until now. And even now it is cheaper. It is just on a relative scale, not as cheap as what it used to be before. Before we were talking about 50 rupees per day versus 150 rupees per day. Now we are talking about 25 rupees per day versus 40 rupees per day. So not that much of difference. So having said that, let me, if anybody has got any questions, please unmute yourself. And while you gather your thought, I'm going to ask Dr. Somaraju to share his thoughts about this particular case, the discussion that we are having, his approach towards this particular scenario. And if Dr. Somaraju, if you could also highlight this unanswered question, that LV clot, how big is too big for us to medically manage, that we should talk about surgical correction for this. Somaraju, sir.
Anup, thank you very much. And most of the issues are already answered by many of our colleagues. I'll want to look at it differently. This patient, tell me yes or no, this patient initial presentation was asymptomatic.
Sir, his initial presentation was heart failure. No angina.
But no MI, nothing. So in which case, fundamental requirement in all coronary artery disease evaluation is to define coronary anatomy before you start anticoagulation, because any anticoagulation oral, when you start, whatever anticoagulation you start, when you have to stop them to do an angiogram later, there are issues of rebound phenomena, etc., and problems of different kind. Fundamentally, before you start any anticoagulation, say method of any kind, coronary anatomy has to be defined, and LV function has to be known clearly. That is already defined. It's not LV angiogram is not essential, but coronary anatomy is fundamental in the ultimate outcome of these patients, not just thrombosis alone. And the size of the thrombus I'll come to later. The size of the thrombus, when you look at, it depends upon, again, coronary anatomy and nature of LV dysfunction, etc. There are no easy information in the literature. You have to individualize. And the size of the thrombus will have to be also defined further as to the freshness of the thrombus versus oldness of the thrombus. And say already a thrombus which is well organized versus not organized, etc. All those things have to be taken. And it has to be individualized. There are no easy answers. And then, having said all this, when you say there is a study from Turkey about, say, non-inferiority, mind you, in a clinical trial, non-inferiority in a clinical trial is different from non-inferiority or superiority in a real world. The real world of medicine we practice, and anticoagulation methods we practice, say in this country particularly, when I look at, non-inferiority and superiority has to be defined differently. It is say warfarin therapy in real world, as you practice, is absolutely imperfect and absolutely inferior to any other alternative methods if you can make it possible or afford it. And that's it. To me, that's my impression. And clinical trials are different from real world superiority and inferiority. And again, re-emphasizing, fundamental in coronary artery disease management is coronary anatomy. First, define it. And after that, you discuss all these issues. And if there are any other questions, I will answer.
Sir, one particular question I have is, how do you look at triple therapy in these kind of patients? I'm talking about particularly middle-aged patients who are really not that high risk for bleeding. When the situation arises like post-angioplasty or post-MI, and if you have to give anticoagulation as another criteria, like for LV dysfunction, LV clot or whatnot, what is your go-to strategy for triple therapy? Do you keep it short, or there are certain tips and tricks that you use to reduce the bleeding risk?
If there is no stenting done, I won't use triple therapy. I'll use only one antiplatelet and anticoagulation. If the stenting is already done and the triple therapy has to be put up with, and there are some risks involved in it, but there is no other choice. But follow your own experience and guidelines in earliest possible. The second antiplatelet has to be stopped, and it depends upon variety of other factors. The patient's age and risk factors for bleeding, etc. The elderly the patient is, and triple therapy is going to be more and more serious issue, and you have to keep that in mind.
And sir, one more question. There is some thought floating around, not established yet, that the anti-10A inhibitors like rivaroxaban and apixaban, there is so-called inherent antiplatelet effect of those drugs, which help us take one of the antiplatelet drug away, versus this is something that warfarin or acetrom does not have. Is it a well-founded thought, or you think somebody just made it up?
Sorry, I don't have enough information on it. I'll leave it to somebody else to answer. To the question of Dr. Praveen, the type of patient he's facing, there is what is called, the type of patient you are facing, there is what is called social determinants of health. And it's not easy to address all those issues. They have to be answered at a social level. And second issue is, say, there's a saying, that your genetic code versus the postal code. The postal code and genetic code, they make a lot of difference in the patient's outcome. And there are no easy answers to some of the questions you raised, Dr. Praveen. Thank you.
Thank you.
Thank you so much, Somaraju sir. One thing that I do want to bring up with your comment is this whole research data versus real world data, and we can spin the story the way we want. The way I spin the story is, when you look at this 90 patient data from, I believe, Turkey, please correct me if I get the country wrong, that in that patient subset, the therapeutic range, when we talk about warfarin, the patients were within the therapeutic range 82% of the time when they were taking warfarin. Now, every single attendee of this session has prescribed warfarin to their patients or acetrom to their patients. And we know our patients don't stay 82% of the time in therapeutic range. They absolutely don't. In the real world scenario, the best that we get is about 60%. So what we are comparing in the trial is a 82% therapeutic range vitamin K antagonist versus a therapeutic rivaroxaban, versus in the real world, what we'll be comparing is a therapeutic rivaroxaban versus more like a 60% therapeutic range warfarin. Because remember, rivaroxaban, the only thing you have to do is just swallow it. That's it. The drug works. And the drug will work provided you are within that weight range. The drug will work. And they do produce the kind of biochemical response that you want it to produce. It is not dependent on any kind of concurrent medication, food, or whatever for that matter. Versus in warfarin, you have to actively ensure that you are in the therapeutic zone. So that real world versus research data, certainly when we interpret in our real life, we do have to interpret with caution. And I concur with most of what the attendees have suggested, that even when there is a lack of robust data for NOAC, I personally still prefer NOAC as compared to vitamin K antagonist for this particular reason, that in the best case scenario also we are not able to achieve through vitamin K antagonist what typically research is able to achieve. And having said that, non-availability of data in a very narrow subset of population should not directly be the reason why we choose one versus another. To answer Dr. Somaraju's question about coronary anatomy, the reason why I wasn't in rush to do it is because there was no any active angina, and there was an infarcted territory. And the most important reason of defining coronary anatomy in this patient was mostly to look for non-infarculated artery, which is circumflex and RCM. And that I wanted to see via different measure. So I wanted to do, it is a very weird way of looking at it, I wanted to immediately do a CT coronary in this patient, CT coronary angiogram, knowing that LED I won't be able to see that well, but I wanted to do it just to see the circumflex and the RCA, and to decide whether how aggressive I need to be in going for the coronary disease treatment as well. So that was my approach, and again, individualized on that particular patient, right or wrong, but that was my my way of doing it. Two comments. Yes, Sumarag sir.
When you say coronary anatomy, whichever way you get the information, it doesn't matter. And whether it's CT angiogram or angiogram, and CT angiogram is a reasonably good choice, as you suggested.
Right, so this is what I ended up doing, and my long-term thought was I do a CT angiogram right now, put them on anticoagulation, and later on, rather than doing an echo, I'll do a cardiac MRI. It will give me an option of looking at the thrombus as well as the viability, and that will help me make a more comprehensive medical decision plan on this patient. So that was my clinical plan on this patient outside of the antithrombotic regimen. I'm reading two comments which have been made on this, or three comments which have been made on chat box. Can heparin infusion for 3 to 4 days and then switch to oral anticoagulant? I think, Praveen, you are mentioning towards large LV clot. And I don't necessarily know the role of heparin infusion versus oral anticoagulant. Heparin early on was given with reference to vitamin K antagonist because of its rapid onset of action. But these days, if you give oral anticoagulant, they work within 2 hours as well. So not necessarily we need to do heparin bridging. That is my thought. And then you also mentioned that the trial we were talking about is from Egypt, not Turkey. So thank you for mentioning that. The trial is from Egypt, not from Turkey. And Srinivas sir mentions that rivaroxaban has 100% availability with food intake and 60% when not taken with food. This is very, very important. This is so crucial. I don't know how much to emphasize. I'll share you a very tiny anecdote with this. It was a catch-22 for us when I was a cardiology fellow. We used to do what you call AFib cardioversion. These patients, we had a very strong AFib program, and these patients would come in the morning to get cardioverted. And by practice, we used to check PT-INR of those patients every morning before cardioversion. Now remember, for cardioversion, these patients had to be nil per oral. And whenever the INR would be down, we had a standing instruction to give them a NOAC and then do cardioversion after 2 hours. Well, the problem was to give NOAC and to make it efficacious, you had to feed the patient. But if you feed the patient, you can't do cardioversion in 2 hours, then you have to wait for 6-8 hours. So that was our recollection from my training days. It is very, very important for your patients to take your rivaroxaban or apixaban with food, because that increases the bioavailability of this drug. Very, very important, very crucial, because there is no way to measure in the blood whether the drug is actually active or not. So Srinivas sir, thank you very much for
Dr. Anup,
yes, sir.
just want to add, in these patients post-MI, there is some evidence to show that overlapping with heparin is helpful and favorable. And overlapping, starting with heparin is generally considered as better way of doing than just waiting for oral.
Perfect. Thank you so much, sir. Shankar sir, do you have anything to add? You are unmuted.
Sir,
is there anything you want to add?
We have been discussing about the triple therapy in certain conditions, like few cases of ACS and peripheral arterial disease, the COMPASS trial, Pioneer trials, they low dose rivaroxaban along with the dual antiplatelet drugs. Is it helpful? Because 2.5 milligrams of rivaroxaban also is available, freely available in the market. So dual antiplatelets, both aspirin and clopidogrel, along with rivaroxaban 2.5. This is well studied, and robust evidence is there.
Perfect. Thank you so much, sir. I'll just highlight on that low dose rivaroxaban. So low dose rivaroxaban 2.5 milligrams twice a day, the patient subset where it is studied is mostly in the preventative therapy, right? ASCVD prevention or secondary event prevention or those kind of preventions. And there, more and more dual pathway inhibition is coming up, where you inhibit the platelet pathway as well as thrombotic pathway. As far as active treatment is concerned, where you already have a thrombus, be it in your veins or your arteries or your LV or wherever, when there is an active thrombus present, there this 2.5 milligrams twice a day or a low dose Novac, that doesn't stand true. There we talk about a full dose anticoagulation supplemented by some antiplatelet. So COMPASS trial that you referred for was an excellent trial where they talked about using rivaroxaban 2.5 milligrams twice a day for prevention of ASCVD, secondary prevention of ASCVD, and it did wonders. For the therapy of an established blood clot, we are still talking about a full dose anticoagulant, like a 20 milligrams of rivaroxaban. And if you have a larger clot burden, even 30 milligrams per day of rivaroxaban, which is 15 milligrams twice a day. And same thing for apixaban, either 10 or 7.5 milligrams twice a day as compared to 5 milligrams twice a day. So certainly the dosing regimen is confusing. Maybe with warfarin, that is one easy thing, that the dosing regimen is not that confusing. You just choose whatever you want for the patient. So
One more,
835, yes. Yes,
one
sir.
more thing, sir. Is there any role of thromboprophylaxis where we suspect, suppose there is in case of a large interval in myocardial infarction and IRA wraps around the LV apex, suppose infarct related artery, if it wraps around the LV apex, if we know by coronary anatomy, by angiogram or nuclear studies, apical wall akinesia on echo, if these three are there, because there is a 5-fold increase in the risk of developing LV thrombus. Even though LV thrombus is not there, but likely to develop LV thrombus is 5-fold. So is there any role of thromboprophylaxis in these conditions?
Somaraju sir, if I may, could you please highlight how do you handle, because I'll say unless there is a LV thrombus, I typically do not give anticoagulant to these patients. When I was when I was in my training, anticoagulant in akinetic LV segment used to be a 2B indication, and none of us used to use it. Dyskinetic segment, some of us did used to use, but I personally have got a habit of not using anticoagulant in these settings unless there is a thrombus present. Somaraju sir, how do you handle this business?
If the patient is not on dual antiplatelets, I will prefer giving them anticoagulants for at least 3 months to 6 months.
Perfect. Thank you so much, sir. Shankar sir, did that answer your question? If single antiplatelet, then 3 to 6 months of anticoagulant. And if I read rest of statement from Dr. Somaraju, that means if the patient is on dual anticoagulant, dual antiplatelet, then probably no anticoagulant. Am I reading you correct, Dr. Somaraju?
Thank you.
Yeah. Okay. It's 8:37. Anybody else has got any other questions, comments about today's session? Okay. If not, Praneeth, your closing comments on today's discussion.
Yeah, before closing comment, one thing about the discussion on that PTNR thing which came up. One of my patients who had mitral valve replacement undergoes this home monitoring of PTNR with the Roche machine, Coagu-Check, which she's been doing for almost last 10 years, and she does compare with the lab value at care, and it is kind of pretty accurate according to her. So that is one information which I wanted to share.
And Praneeth, while you talk about that, do you know the cost and availability scenario about that particular device, Coagu-Check?
Yeah, so I inquired about that. So the machine costs about 30,000. Okay, the device is 30,000, and the strips that we need to check costs about 2,400 per pack. It amounts to something like 300 rupees per strip that they are doing. So if we look at it, it's probably economical, but it's an one-time investment that we need to make.
Right, and I'm guessing the machine needs to be bought, right? This is not a rental machine or anything like
So the machine has to be bought, which costs 30,000, and the strips have to be purchased. So that is where sometimes it's a problem of availability of the strips. But so she purchases in bulk, and she's been managing her PTNR at home for at least last 10 years.
Perfect. All right. Thank you, Praneeth. Let's close this, your comments, and then we will say goodbye.
Yeah, so closing comments, an interesting discussion. Again, a gray area where guidelines do not answer the practical considerations with increasing comfort of use of NOACs with almost every specialty from physicians to cardiologists to neurologists. Obviously, NOACs are becoming the drugs of choice in various conditions where you need to reduce the thrombus burden. And probably it's only a matter of time where few more studies are done in a more systematic fashion where these become even recommended in the standard guidelines. And wherever every patient has to be individualized, and where comfortable, use the drug which you know you can prescribe it better, and you know that your patient will take it better and will get a good outcome out of it. Thanks, Ajay.
Perfect. Thank you, Praneeth. And I thank all of you for attending today's session. These are really common scenarios, and we don't have a straightforward answer. So it is good to get each one of yours feedback. And before I let you go, reminder from next week, we will be starting our huddle at 7 p.m. Currently, we do it at 7:30 p.m. From next week, we are going to start at 7 p.m. The same will be reflected on my invitation as well. And if you have any ideas or thoughts that you think we should be discussing in our huddle discussion, please shoot an email to me or WhatsApp me, and I'll be happy to put it in one of the discussion topics. I thank you all for your time and attention, and I hope to see you next week. Thank you all. Good night. Thank you.